Good morning once again from a cold and windy Cape Town, from wherever you're joining us from across the country and from the continent. It really has been quite cold at this part of the continent. It's been snowing in parts of the country over the last 24 hours. We hope it's better weather from wherever you're joining us from. But I see here we have reached quorum, so we're going to begin now. A reminder just to continue registering as we are continuing with your name, institution, email address, and country in the chat function. A reminder once again was that this platform's inception really was to try to bridge the gap as COVID-19 impacts upon trainees across the continent. So really the invitation is to people not only in South Africa, but people across the continent who want to participate in our academic program to please email me and we can slot you in appropriately. So just some house rules before we kick in. May I please ask everyone to keep their microphones muted throughout the meeting. If you have a question during the course of the discussions, you can either write it down on the chat function, or if you want to ask it personally, you can just use the raise hand function on the tab, and I will see you, and then you can go ahead and ask your question. Okay, great. So I think we'll just dive in. Today being Head and Neck Day, we have 3 cases lined up under the theme or subspecialty of head and neck, or disease of the head and neck. We have 2 presenters from the University of Cape Town and 1 from the University of the Free State. A welcome to our presenters. So may I please ask our first presenter, Dr. Matthew White, Registrar from the University of Cape Town, to please begin.
Tasia, can you just enable me to share my screen?
It's done.
Yeah. Okay, so good morning, everyone. My name is Matthew White. I'm a registrar at UCT, and thank you, everyone, for this opportunity to present this morning. So just a brief disclaimer, I've written consent from the patient to publicly share their clinical details on this platform, and further, all my academic content is referenced. So to dive right into it, my case was a 44-year-old female who presented with a 1-year history of progressive dysphagia to solids, halitosis, unprovoked choking episodes, often at night, globus pharyngeus indicated at the level of the cricoid. She also noted a noisy gurgling sound in her neck during deglutition, and she did also report some symptoms in keeping with reflux. Importantly, she had no associated dysphonia, odynophagia, neck pain, neck mass or swelling, hematemesis, hemoptysis, loss of weight. In terms of her comorbidity, she was a known hypertensive with a good baseline function and effort tolerance. She had no risk factors for squamous cell carcinoma of the head and neck. She was a non-smoker, no history of alcohol use. Clinically, she was a well patient. Examination of her oropharynx and oral cavity was unremarkable. Her neck showed no associated neck masses or lymphadenopathy. She had no local point tenderness and no Boyce sign to note. Flexible nasal endoscopy was done, which revealed a normal postnasal space in the larynx with mobile symmetrical vocal cords. Some pooling of secretions was noted in the post-cricoid area, but there were no sinister mass lesions to note. We followed this up with a barium swallow. I don't know if one of the finals candidates would like to just comment on the findings. Any volunteers?
Hi, Matthew. It looks like a short anemia from Stellenbosch. It looks like there's a diverticulum. The level there, I'll have to just count the vertebra, but it's certainly in keeping with the symptoms.
Yeah, so Sean, you're on the money there. Sorry that barium swallow didn't project that well, but you can see it more clearly in this single shot. There was roughly a 3 by 4 centimeter pharyngeal diverticulum at about the level of C4, C5. So perhaps moving on, I don't know, Sean, if you'd like to comment on any additional special investigations you might like or think may be relevant in a case of a Zenker's.
I think the symptoms largely determine your management. There is a very small risk of malignant change. I think it's in the region of 0.25 to 0.5%. So it's something you just need to keep in mind. It's a bit unusual in this age group. It's usually older patients, and the pathophysiology is related to well, there's a few theories, but related to either spasm or discoordination of swallow, so that you get increased intraluminal pressure, and then you force the diverticulum out, so the intraluminal lining. So in terms of investigations, I think pretty much an adequate EUA and looking into this, in my mind, would probably be enough. You want to treat it if it's symptomatic, and at the same time, when you go in to treat it, if you're doing it endoscopically, you can open up and have a good look into that cavity to make sure there are no malignant changes. Just to note, you're obviously going to need a fair bit of neck extension when you treat the patient or when you take them to theatre. So you just need to be sure that that the neck mobility is okay and there's no problems with that before theatre. So potentially C-spine views, if that's a concern. I can't think of anything other specific that one would want to do.
Okay, great. Yeah, so I mean that's exactly it. So a barium swallow is diagnostic, and it's the gold standard of investigation, as you said, and very rarely anything else is required. Some of the literature does state that it further allows one to assess the competency of the lower esophageal sphincter at the same time, where the theory is if it's found to be incompetent on barium swallow, then cricopharyngeal myotomy may result in severe post-myotomy reflux. There is some mention that in cases of inability to tolerate barium, a FEES can be done, where they talk about the rising tide sign, which may be elicited with swallowing a small amount of fluid. The bolus is seen to initially disappear and then rise up into the post-cricoid area again. Esophageal manometry is not routine, but like you said, it's rarely performed to exclude an underlying spasmodic or dysmotility disorder. And then the other important investigation is just a chest X-ray. A lot of these patients are either having silent or active aspiration, especially at night, and to assess or exclude any secondary aspiration, pneumonitis, fibrosis, or chronic bronchiectasis. And then, yeah, so C-spine X-ray seems also fair. I didn't actually think of that. And then you already covered my next question, was malignancy in Zenker's diverticulum, does it exist? And then perhaps you did partly answer the second part to that question, was what may make you suspicious of a malignancy in a Zenker's diverticulum. I don't know if you or anyone else wants to try elaborate on that.
Hi, Matthew. It's Kwame from WITS. Malignancy in a Zenker is if a patient has unusual pain or if there's blood in the sputum or the food that's regurgitated has, or if there's any other neck notes that you find clinically might make you suspect malignancy.
Okay, great. Yeah, so you and Kwame and Sean are quite right. As Sean said, there's a incidence of about 0.5%. It's suspected to be secondary to chronic irritation and inflammation due to food stasis within the diverticulum. And as you all said, pain is a suspicious feature. It's not normally found in benign Zenkers. An increase in symptom severity, hemoptysis and hematemesis are ominous signs, lymphadenopathy. And then just on barium swallow, in cases of malignancy, they talk about having a constant filling defect on barium swallow, which is a constant filling defect between films. You may get a filling defect with retained food debris within your diverticular sac. However, that normally migrates or moves or changes between films, whereas a filling defect due to a tumor or mass lesion or ulcerative lesion will produce a constant filling defect. And then, like Sean quite rightly said, prior to performing any definitive procedures, one should closely endoscopically inspect the pouch and its epithelium in all cases prior to doing anything definitive. Okay, so then that moves on to the next question. I don't know if anyone wants to just briefly list the possible management options.
Hi Matthew, it's Wisha from Cape Town. So management depends on the patient's symptoms. You could do nothing if the patient is asymptomatic, if it's incidental finding. But then if you do opt to do something, then the surgical management can either be endoscopic or external. And there's different options. So if it's endoscopic, then we have the option to use laser, or we can use stapling. Yeah, and then externally, then that would involve like a cricopharyngeal myotomy and removal of the pouch. Those are my options.
Yeah, so exactly. So as you said, the first option is one can do nothing. If the patient has no or minimal symptoms, a small diverticulum with no sinister features, which we mentioned earlier, which may indicate an underlying diverticulum malignancy. The patient can just simply be observed with perhaps some dietary modification. And just to note that many of these patients are often elderly and infirm with multiple comorbidities. So avoiding any intervention or doing the least invasive intervention possible is often optimal. And then you mentioned some of the transoral endoscopic approaches, which include flexible endoscopic diverticulotomy and cricopharyngeal myotomy. And then the rigid endoscopic procedures, which can either be done with a CO2 laser, a stapler, just diathermy, or even a harmonic scalpel. And then the open transcervical external approaches all would include a cricopharyngeal myotomy, most commonly with a diverticulectomy. In the older days, a diverticular pexy or diverticular inversion is also described. So just to elaborate a bit more on the transoral rigid endoscopic procedures, the goal of these approaches, as you mentioned, is to divide the common party wall between the esophagus and the diverticulum, and thereby incorporating the diverticulum into the esophageal lumen, and in the process also performing a cricopharyngeal myotomy. So the endoscopic procedures has some advantages. So it's obviously less invasive with a lower complication rate and a shorter hospital stay. And in cases of recurrence, revision surgery is further more straightforward, where in cases of a recurrent diverticulum, either a repeat endoscopic procedure can be done, or you can convert to an open approach. Disadvantages, there aren't many, but there's a theoretical risk of a missed carcinoma through, it's thought, by not excising and submitting the entire sac for histology, but there are no cases in the literature to support this. And then you're also limited by the need for general anesthesia and the usual factors compromising transoral access, like Sean mentioned earlier: neck extension, Mallampati score, retrognathia, teeth anomalies, etc. There are some differences if we compare the different techniques. So the CO2 laser has the advantage of being able to divide the entire length of the party wall without leaving a residual shallow defect, making it particularly useful for small diverticuli. It is cost effective, as despite its initial cost, it's multi-use and can be used for other interventions. And it was initially in the earlier studies quoted as being more effective with less recurrence than the stapler. However, newer refined stapling techniques show comparable outcomes. In terms of the GI stapling devices, the arguments in support of it's perhaps faster. It cuts staples and seals simultaneously, and therefore may have a theoretically lower risk of perforation and mediastinitis. Listed disadvantages include that in a small Zenkers, due to the nature of the stapler, the diverticulum may be too shallow and you may not be able to catch the entire lip of the diverticulum. Again, it's single use and an expensive option. And you may be able to overcome, newer studies in the literature showing that you may be able to overcome the limitations of the length of the bar, either by cutting the anvil of the stapler or by applying retraction sutures on either side of the diverticulum at the time of surgery. Electrocautery is also an inexpensive, readily available option, but has the theoretical limitation of increased thermal spread with a possible risk of injury to the recurrent laryngeal nerve. And then just moving on to a newer modality, Z-PERM it's an acronym for Zenker's per oral endoscopic myotomy, which is a newer technique which uses a standard flexible gastroscope with a modified clear cap and routine CO2 insufflation. There are multiple variations, but essentially the mucosa overlying the bar is incised with cautery or laser. Submucosal tunnels are made on either side of the bar, and then the bar is submucosally divided and the mucosal defect is closed with endoclips at the end of the procedure. Advantages include that it does not require GA and can be done in a GI suite with under minimal sedation. And it's also not limited by the usual access issues which may negate rigid endoscopy. In the largest retrospective series which I could find, published in 2020 of 75 cases, it showed a success rate of 97%, a complication rate of 6.7%, including 4 perforations, an average procedure time of 52 minutes, and a mean length of hospital stay of 2 days. Okay, so then moving on to our next question for the candidates, what are the indications for an open transcervical approach? I don't know if anyone wants to take that.
Thanks, Matt. I'll just like to just mention we have about 5 minutes left for this case.
Okay, sure.
Hi, Matthew. It's Bill case. Just from what I can remember, it's already there. It's fine.
Sorry, Balkis.
No, it's okay.
Okay, so sorry, I jumped the gun there, but so indications obviously include where there's failed transoral access, where there's perforation during an attempted endoscopic procedure, where there's confirmed diverticular carcinoma, and obviously where there are resource or skill constraints. The obvious it has comparable rates and recurrence rates to the endoscopic procedures, but it's obviously more invasive, with a complication rate at approximately 20% compared to the 10% complication rate in endoscopic procedures. It's associated with a longer duration of hospital stay and a delayed return to oral intake. And in cases of recurrence, salvage is also technically more difficult. So just to return to what happened with our patient, the patient was taken to theatre with a view to performing an endoscopic diverticulotomy. The procedure was abandoned due to limited transoral access. The diverticulum was packed with gauze, and we converted to an open transcervical diverticulectomy and cricopharyngeal myotomy. She received antibiotics for 24 hours. The drain was removed once her output was less than 50 mils. She had basically an uncomplicated post-operative course. She was kept null pass on nasogastric feeds for 7 days, at which point a contrast swallow was done to exclude a leak, and she was discharged home on a full ward diet. 2 weeks later, at follow-up at the clinic, she reported complete symptomatic resolution. Her wounds had healed nicely, and this is just the barium swallow taken in the median post-operative period, showing no residual diverticulum. Thank you.
Excellent. Thanks very much, Matthew. I'd like to invite Professor Fagan for any comments, just as we wrap up this case.
Well, thank you, Matthew. That was a really good presentation. Just one or two things I can add, perhaps. You spoke about the checklist prior to surgery if you're doing endoscopic approach. Just important to look at the top teeth and make sure they don't have crowns or cap teeth, because the scope that we use places a lot of pressure on those on the top teeth. I wouldn't do a cervical spine X-ray as a routine, but most certainly if a patient has any history of cervical spine issues, or for instance rheumatoid arthritis, you must be concerned about that. And I tend to use the endoscopic approach for virtually all my cases. But as you pointed out, if you have a very small pouch, then you have to use CO2 laser, and you can't rely on the stapling device. And also, I mean, I find that doing the endoscopic approach is possibly one of the most stressful operations that I do in the head and neck. Because of the bulkiness and the size of the diverticular scope. Because to get the scope in the right position, you are at risk of perforating the wall of the pouch, and so you must be really careful when you place the scope. Once the scope's in place, then it's a very quick procedure. But really, it's placing the scope that requires quite a lot of skill. But otherwise, I thought that was a great presentation, and I have nothing else to add.
Okay, fantastic. Thank you very much, Matthew. Thank you, Professor Fagan. I think we were right on course to moving on to our second case. I'd like to invite Dr. Devesh from the University of the Free State.
Hi, Tasir.
Hi, Devesh. You can share your screen. Yes.
Great, thanks. Good morning, everyone. My name's Devesh, and I'm from the University of the Free State. And I also have nothing to disclose and have consent from the patient to share his information.
Devesh, sorry to interrupt. It's just on a presenter view. Do you just want to maybe just put it on normal, on sort of on a slideshow view?
No. Is it still this here?
Yeah, it's still on presenter view.
Can you just give me a second?
Sure. You can just unpick use presenter view there.
There we go. Cool. So as I was saying, I have nothing to disclose, and I do have permission from the patient to share his information. And I have the case of Mr. SM. He's a 65-year-old male. He presented with a hoarse voice for 6 months. He had no breathing difficulty, no pain that was associated, no dysphagia or dynaphasia, no cough, and loss of weight for 2 to 3 years with no other constitutional symptoms. He wasn't really able to quantify his weight loss. On past medical history, he's HIV positive and was diagnosed in 2006 and started on ARVs. He's also had pulmonary TB 7 years ago. Of note is that he smokes cigarettes and cannabis. He uses alcohol, and he's not employed. So I'm going to also ask maybe Bushle if you can help us to gather some ideas on the differential diagnosis and what you're thinking from our history.
Thanks, Devesh. So a 65-year-old with a hoarse voice who's also a smoker is laryngeal carcinoma till proven otherwise. But so there can be other differentials, of course. So carcinoma is way up there. But I'm also worried about things like TB of the larynx, since he's had TB before. It could also just be benign laryngeal pathology, so benign vocal cord cysts or polyps.
Yeah, great. So there's quite a lot of things to think about. And as you mentioned, CA and malignancy is quite high up on the list. And then we'll think about other benign vocal cord lesions as well as infective causes of hoarseness. So in physical exam, he was, vital signs were normal. He was quite wasted, and he had a flexible endoscopy, which showed that the nasal mucosa was edematous and hyperemic, and he had a raised white lesion on the right false cord. His vocal cords were mobile, but the mucosa appeared inflamed, and the rest of his ENT examination was normal. And we proceeded to do some investigations for him. So we did a full blood count, urea and creatinine and electrolytes, and a chest x-ray. And his chest x-ray is showed on the right, and it was reported by the radiologist to have features in keeping with lung fibrosis. And radiologically, their diagnosis, differential diagnosis, was from TB or an infective process. So I just want to ask, what are our thoughts and what would we do next? Maybe I can ask Kwame if he has any ideas.
Hi, Devesh. Thanks. So with that lesion that was seen on the flexible scope, I'd like to proceed and probably do a pan endoscopy and do a thorough EUA of that larynx and take biopsies. And because we're worried about a possible malignancy, send for histology and also MCNS and TB, just to confirm the diagnosis.
Great. That's exactly what we did. We went to theater for an EUA, and we noted that there was a wide raised lesion on the right false cord, and the vocal cords were mobile, and there are no other abnormalities. And he had no palpable neck nodes. And we took some biopsies, as you mentioned, for histology, MCNS, and TB. And his follow-up histology came back, there were multiple specimens. And in summary, it shows squamous dysplasia And because they're two specimens, there were varying degrees of dysplasia, so moderate and severe dysplasia that was identified. And his TB, MCNS, and the TB culture was negative. So our plan was a combination of conservative measures to stop smoking, use anti-reflux therapy, and we decided that serial biopsies and surveillance was what we would do for him. And I think there are a lot of controversies around the management of these patients. So I do have quite a few discussion points that I'd like to open the floor on and get the opinion on what factors do we consider when deciding how to manage these patients. The classification according to squamous intraepithelial lesions. Does excision techniques make a difference? What is the role of radiation? And what's the best follow-up strategy and the timing of that? And yeah, I'd like to open the floor and hear the opinion, and then I can maybe comment on each of those points.
Right, Devesh, can I make a comment?
Yes, Prof.
There's always a concern to me, and I've been caught out by this myself in my career, is where you have a mass which of the false vocal cord, as you've had, and you biopsied it, and it comes back as dysplasia or even less than that, that you might have a tumor sitting in the ventricle, and it's actually hidden from view, and it's elevating that false vocal cord. And so at times one has to use a laser, or you have to use really deep biopsies and go through the false vocal cord into the ventricle just to ensure that you haven't missed something.
Devesh, are you there?
Is there anything else that anyone wants to mention? Or what they do? Maybe I should just kick off. So with the factors to consider when treating these patients, I think it's quite important to document the foci of the lesion. So is it a single, is it multiple foci, is it a confluent lesion, and how much of tissue you're going to remove. And then, as Prof said, there might be something underneath the lesion, so you might need to go deeper, and those all influence what your choice would be or how you would manage them. And then functional status plays quite an important role, and in this patient, it was quite evident that post his pulmonary TB, he had fibrosis and quite poor respiratory function. So that would also limit what our treatment options for him would be. In terms of the squamous intraepithelial lesions and high grade versus low grade, this has to do with the classification of the dysplasia and the change from a 4-tier to 2-tier system. So with the higher grade, this encompasses your severe dysplasia, and your lower grade, more your mild and moderate dysplasia. And these also can indicate the risk of malignant transformation. And in a higher grade, there is a risk. And the literature varies, but the range is between 10 to 25%. So that's something to keep in mind when looking at your histology result. In terms of excision technique, Prof. Hagen just mentioned laser, and the other techniques one can use is cold steel, for example. And does it make a difference in the outcome of the history of the disease? And the answer to that is no. However, when using laser, the edges of the biopsy will be charged. So it's always important to remember to take deep biopsies so that you do have an indication of whether your margin is clear. And radiation, this is interesting. It is documented in the literature, and whether there's a role to play for radiation or not is debatable. And the school of thought is that it is not a carcinoma, so it is just dysplasia. So would you radiate? And they have also termed the dysplastic lesions intraepithelial carcinoma. So that could be one of the indications. The other things is recurrent lesions, the functional status of the patient, and patient's choice. I'm not sure if anyone wants to comment on that, of the use of radiation.
Vesh, can I ask you a question if you don't mind?
Yeah, sure.
So just from my understanding from what you're saying is that you see if you have a localized mild to moderate dysplasia, you'd be better placed to just excise that portion because there's minimal functional deficit. But if it's sort of a widespread mild to moderate dysplasia, then you would think about observation strategies or otherwise. But if it's, as you said, a focal severe dysplasia, you would rather manage that as a T1 laryngeal carcinoma. Am I right?
Yes.
Okay.
However, radiation does have the risk of also malignant transformation and morbidities associated with. So, you know, is radiation something we would consider? Is sort of what I'm asking.
But perhaps I can comment here. You know, so if you have extensive some high-grade dysplasia, stroke carcinoma in situ, where we really can't excise it fully, so using endoscopic sort of techniques, you know, then those are the cases where we might consider giving radiation therapy.
All right, thanks, Prof. And the last point that I would like to discuss is the follow-up strategy and what is the best follow-up modality for the patient. Should we be taking photographs? Should we use stroboscopy, which is not widely available? And how often should we see these patients and for how long? And I think there are guidelines that exist, but there's no clear consensus of what's the best method for follow-up and the best timing. We have used 3 months, so we see our follow-up every 3 months, but I think that's also open for discussion.
Thanks, Devesh. I don't know if you want to maybe, or Professor Fagan, really just to start wrapping up the case. We just have about 5 minutes left.
Well, can I ask Kenneth Baidu to comment? He's a head and neck surgeon in Ghana.
Yes, good morning, everybody. Having listened to the presentation, I would have in theater also use an endoscope to look into the ventricle like Prof mentioned. And we've been cut out once or twice, having missed a ventricular lesion. And this started at the second EUA, we found a lesion in the ventricle. Now with the dysplasia, we had a similar case which we excised. Actually, before then we didn't have a laser, so we went to the UK, had it excised. And subsequently, still after about follow-up for about 6 months, we realized that a recurrence of the lesion for which he had radiotherapy. And now he's come back with post-radiotherapy and he's had a salvage laryngectomy. So follow-up, like you rightly said, should be close. We do it initially 1 month, so we are for about 6 months, and then we extend the follow-up period if it's more like it remains stable. But we also, if the patient's hoarseness doesn't improve, sometimes we go back to biopsy because, to be honest with you, though we have very good pathology, sometimes the descriptions, dysplasia, it's always a gray area which some of us think we'd rather better off taking multiple biopsies and be comfortable that there's nothing done to wait and then you are caught out with something significant. So that's what I can add to this.
Thank you.
Thanks, Devesh. Thank you, Professor Baidu, as well. I see here that you made the comment about follow-up period as well, and just on the chat function, people are questioning why we said 3 months, but as you said, you normally see them a month after you have picked up the lesion. So I think it just demonstrates the varying follow-up strategies. There are a couple of other questions on the chat function with our first case, but I think at this juncture, I'd probably want to move on to our last case. And if we have some time right at the end, maybe we can address them. So I'd like to invite our, thanks Devesh, I'd like to now invite our third presenter, Bilqis Al-Falah from the University of Cape Town, who is going to now present our final case that ties in quite nicely or is a nice follow-up to our second case.
Thanks, Desir. I'm just sharing my screen.
Sure.
Okay, so good morning, everyone. My name is Bilqis Al-Falah. I'm a ENT registrar at UCT. So I have no disclosures, and I got patient's consent to use her personal details in the presentation, and my studies are referenced. So I have a Mrs. X. She is a 67-year-old female, non-hypertensive, well-controlled. She presented with 8 months history of mainly duodenodysplasia with a weight loss, which she doesn't know exactly how much. She also had a hoarse voice, complained also of a right otalgia. Then she had no history of reflux, no history of cough or night sweats or fever or previous history of pulmonary TB. She is a smoker of a 30 pack years history. She denied any alcohol intake. So on examination, she was a clinically well lady. She had a hoarse voice, but there was no stridor, no shortness of breath, and no distress. So throat and nose exam was deferred because of the COVID risk, and then the neck exam revealed a right level 2 single mobile node with ±3 centimeters size. And then we did flexible endoscopy after confirmation of COVID negative result. And she had a large exophytic mass involving the right true and false chords, a right area epiglottic fold, and this right chord was fixed. And then she had a normal left chord on the other side. Then we proceeded with investigations. We did bloods, FBC, urinary electrolytes, all were normal, and chest X-ray, it was not suspicious of any metastasis. And then she was referred from a primary hospital with scope and biopsy results, which confirmed the laryngeal squamous cell carcinoma. But the scope was not given in details regarding the staging. So it is discussed at multidisciplinary team, and then she was assessed by a speech therapist if we are proceeding with the laryngectomy for voice rehabilitation. And then she was taken for theater for staging scope, and then ± to proceed with the total laryngectomy and neck dissection. So in theater, tumor, as I mentioned, on the flexible scope, and then also was an involvement of the medial wall of the right pariform, but it was free from the prevertebral fascia, and esophagoscopy was normal. So then she was staged as a T4A into C because she actually had bilateral nodes. And so we proceeded to do a total laryngectomy, bilateral modified neck dissection, and right thyroid lobectomy. So I just wanted to raise some discussion points, when we decide to do a thyroidectomy, or when do you manage the thyroid gland surgically? Anyone, if anyone can comment on that.
Hi, Balgiz. It's Devesh from UFS. So with thyroidectomy, if you have, I think there are three sort of indications that I know of. One is direct involvement of the thyroid. The other is subglottic extension. And you mentioned, I think, medial wall of the piriform fossa, so involvement of the hypopharynx. Thanks.
Yes, true, Devesh. So it's, as you said, if it is involved with the tumor, either clinically or radiologically, if it is a subglottic tumor or there is a subglottic extension of more than 1 centimeter, or involvement of the hypopharynx, so we are doing it as part of level 6 neck dissection. So my other comment is regarding postoperative commencement of feeding. I'm not sure what other people doing in the rest of the countries in Africa, because in my country, Libya, still we are not doing the early feeding protocols. I would like just to hear some comments from other people from other countries.
But Kenneth, you want to comment on the Ghana experience?
Yes, two comments. One on the thyroidectomy. What I've found in my practice is all the indications mentioned are in order, but we've been caught out a few times when intra-op, I usually do the side of the disease first. So you want to, let's say in this case, you want to do a right thyroidectomy. In doing that, when you get to the opposite side and you realize the contralateral thyroid is in a worse state than the ipsilateral thyroid, then you end up doing a total thyroidectomy. So what I do now is I'll do both sides, leave the thyroids, and then when I'm satisfied the contralateral thyroid is healthy, before I take off the ipsilateral thyroid. But we definitely do thyroidectomy once with the indication stated. Now with the feeding, we follow the old system where we feed around day 7. We keep them with NG feeds, or depending on whether you want to do a voice prosthesis or use a Foley's catheter feed. But then we feed them for about 5 to 7 days. We are waiting for day 5 to see whether we have a perforation, that's pharyngocutaneous. But then if that is negative, then we go ahead to feed around day 7.
But are there any comments from Ethiopia or from Kenya?
Hello.
Hi, please go
Hello.
on. We can hear you.
Okay, it's me, Mr. Getachew from Ethiopia. I'm an NT registrar, and we usually do on post-laryngectomy patients. We usually insert NG tube feeding, like we insert the NG tube during the intraoperatively, and we usually keep the NG tube for about 3 weeks, depending on the patient's response. And usually we do the 3 weeks protocol in order to have the normal resume. Before resuming the normal food. So we usually manage those patients to have NG tube feeding for about 3 weeks. Thank you.
Professor Hagen, I see that's quite different from the study Bilkis is showing here. Maybe
Yes.
you comment on that, Bilkis?
So actually in our institution, we do an early feeding protocol for our laryngectomies. So this is our protocol. So on day 1 post-operatively, we give intravenous maintenance solutions and stomagastric feeds or nasogastric feeds. And then on day 2, we actually start giving patient clear fluids together with the stomagastric feeds. And in day 3, we upgrade to free fluids. Day 4, soft diet as patient tolerated. And on day 5, they can be on a normal diet if they are comfortable with that. And then this is realizing in regarding to the Profagan's study, which was involving 40 patients who underwent total laryngectomy for an advanced SCC of the larynx. And they actually divided these 40 patients to in halves. And then 20% of patients who started early feeding protocol, only 20% they developed the pharyngocutaneous fistula, comparing to a 15% of the delayed feeding protocol. So we just, from this paper, it was concluded that early feeding process in post-total laryngectomy is recommended either both in developed or developing centers. And then if Profagan can correct me, we delay the feeding if a patient required a flap for pharyngeal reconstruction, or we were worried about the very tight closure of the neopharynx, or if patient had a previous radiotherapy and it's like a salvage laryngectomy, which we wait for a week and then do a barium swallow to confirm if there is any fistula. Profagan?
Yeah, perhaps I can comment there. So the other two co-authors on the Jeffrey Titi from Uganda and Joyce Aswani from Kenya. And recently I wrote a book chapter for a textbook where they asked me to do a systematic review of early feeding. And in fact, all the studies out there that have compared early feeding with delayed feeding show no difference in terms of leak rates. So I really am quite confident that one can feed these patients early, provided, as you said, there aren't complicating factors such as putting a flap in there, or patients had previous radiation or chemoradiation.
And then just in terms of the speech rehabilitation post-total laryngectomy, there was a systematic review in 2010, which they found that we know the main methods for voice rehabilitation are the esophageal speech, electrolarynx, and tracheoesophageal fistula. But each one of those has advantages and disadvantages, and we need to take in consideration each patient separately regarding the age, the physical condition, economic states, and then also the facilities of speech therapy which can be approached by the patient. So I'm not sure if any other one can comment from other African countries what are the options for post-operative speech rehabilitation.
All right, so I'll make a straightforward comment. We, by and large, use the electrolarynx in most of our patients, but we get that odd patient who comes and can afford a voice prosthesis, which we use it for them. The problem with that is because it has to be that recurrent expenditure of getting the voice prosthesis changed. Sometimes some of them, after a while, would want to go back to electrolarynx. We are not doing too much of esophageal speech, but we get to do what is called a forced whisper. Some of them somehow try some modified bit of esophageal speech, but it's more like a forced whisper. Thank you.
Thank you. Tasir?
Thanks very much, Bilquis. Professor Fagan, any concluding remarks on this case?
Yeah, perhaps just to comment on the role of primary chemoradiation or radiation. that was mentioned there as a discussion point, and just to say that the contraindications for primary chemoradiation are really when you have a bulky tumor, when you have a compromised airway, or you have a dysfunctional larynx, such as a patient who's aspirating, because you're unlikely, or if you have thyroid cartilage involvement, because those patients don't do well. And the last one would be if you don't have access to CT scan or imaging, so you can stage these patients properly. So we tend to operate on most of our T3 laryngeal cancers because they tend to be at the more advanced end of the spectrum. And of course, the last issue to consider with primary chemoradiation is whether you are able to do your proper salvage surgery in your unit, which would require you often to bring up a big major flap to cover your repair.
Thank you very much, Professor Fagan. I'm just going to look at the chat function just to address certain questions. So we'll extend our time by about 10 to 15 minutes just to make sure we cover these. So there's one question, I think I can direct this to Devesh, is just a comment on how to monitor dysplasia. So the question is, how do you monitor it? Is it you just do biopsies, or do you scope them regularly? Is there a role for radiology in these cases? Devesh, do you want to perhaps maybe reply?
Thanks, Tasir. So yes, we monitor by doing serial biopsies in theater and EUA and documenting the size of the lesion, any changes in those. And as was said earlier, multiple biopsies are better so that you get a wider view, because dysplasia has variety of severity. So multiple biopsy, EUA, and documenting the size and location of the lesions. In terms of imaging, they don't play a role in the monitoring. In the literature, stroboscopy has become quite popular as well. So stroboscopy in combination with photographs are sort of the best method to monitor them, but imaging does not play a role, not that I've read or know of.
Thanks, Devesh. Professor Fagan, any remarks on that question?
No, I've got nothing else to add to that.
Okay, thank you. There are just two more questions on our first case, and I'll invite Matthew White maybe to just comment on these as well. So how would we manage an esophageal perforation during an attempted endoscopic repair? And is there room for conservative management? I think the question about conservative management was addressed, but maybe Matthew, do you want to comment on any potential complications that could arise during your repair?
Yeah, sure. So in terms of managing a perforation, as was said, it usually occurs at the time of rigid or sometimes flexible endoscopy. The one option which is described is to endoscopically suture or staple or clip a small perforation, and then obviously manage with a nasogastric tube feed and a follow-up barium swallow. But what's more commonly described is converting to an open approach, so via transcervical excision, exposing the diverticulum and excising it by diverticulectomy. The obvious concern is that a perforation now creates a communication with the retropharyngeal space and danger space, and there's a risk of mediastinitis. So I would think maybe Prof. Fagan could confirm, but I'd also think an extended course of antibiotics, something like Augmentin, for perhaps 7 days would also not be a bad idea.
Yeah, perhaps I can comment on that too. The other concern with a perforated pouch is that the pouch isn't surrounded by muscle. It is actually it's actually the pouch is simply mucosa and submucosa, which is extending through the muscle layer. And so if you have a perforation of the pouch, then you should be concerned that it's not going to heal quickly. And so these patients can get you into trouble, and you probably want to at least place a drain there if they're not responding to conservative management, as Matthew had alluded to. So there can be a problem in terms of managing conservatively.
Thank you. Just a follow-up question on that is that after you've managed these cases, I think they're referring to endoscopic management. What is the recurrence risk from your experience? And secondly, maybe you can answer the two questions at the same time, is that how would you manage a post-op leak after an open approach on the Zenkers? Professor Fagan, maybe would you like to maybe comment on those two questions?
Well, the first question, really, I can't comment on my own figures because I haven't analyzed them, and as surgeons, we're always optimistic about our results until we analyze them. But perhaps Matthew can just comment on the data out there in literature. The second question was if you have a leak after an open approach. Well, you have to deal with it like you would with any leak, and so you want to keep the drain in longer if the drain isn't there, or you might have to go and drain that space. But to go and repair it post-operatively would be really difficult because you're working with a structure which is right behind the larynx, and so I would probably simply place the drain and give the patient antibiotics and they manage them conservatively.
Matthew, do you have any other comments to make just on those questions?
Yeah, in terms of recurrence, there's a lot of literature out there, but it seems to be, it's actually quite high from what I can see. It's somewhere between, older studies quote 10%, the newer studies using kind of endoscopic techniques seems to be about 7%. It also depends on how you kind of define recurrence. I saw one of the follow-up questions was to point out the residual diverticulum. Just in relation to that, there was no residual diverticulum on that follow-up barium swallow, but quite often and perhaps one of the reasons not to do a follow-up barium swallow is the radiographers will quite often report a residual diverticulum on follow-up barium swallows, either because there's a small residual lip or because they're falsely interpreting the kind of the neo-megapharynx you've created by joining the party walls. So, and again, you only really have to act on it in terms of recurrence if they're symptomatic. I don't know if that answers that question.
Thanks, Matt. And maybe just a comment as well, and maybe you can shed some light on it, is that, the theoretical risk of once you fiddle around with the upper esophageal sphincter and you do your myotomy, the theoretical risk post-operatively of regurgitation and reflux. Did you come across any of that when you were reading?
I did mention a bit earlier on that one of the theoretical concerns and reasons to do a full-length barium swallow from kind of the level of the pharynx to the diaphragm is to assess the competency of the lower esophageal sphincter. And in cases where it's found to be incompetent and there's reflux at the level of the lower esophageal sphincter, if you intervene by doing a cricopharyngeal myotomy as part of your management, there is a concern that you will render the patient with quite severe gastroesophageal reflux and laryngopharyngeal reflux disease. But I'm still not sure how that would alter your management.
Okay. Thank you very, very much, Matthew. Professor Fagan, I'd like to wrap up this session. Any concluding remarks from your side before I wrap up? I'm not sure if Professor Fagan is still there. we seem to have lost him, but there's some questions I see here on total laryngectomy, and I think I'll have to end today's session here just because of time, but I'd like to invite everyone for next week's session on Wednesday next week at 1 p.m. South African Standard Time. We have a full session on advanced laryngeal cancer. And next week, Friday, with our theme on Fridays now being the different subspecialties, we have a full day of cases under the theme of otology. So I'd like to wrap it up here. Professor Vagan, any concluding remarks from your side?
No, just to thank the presenters. They were really good cases, and also to thank the commentary from our colleagues from around Africa.
Okay, thank you very, very much. Thank you once again to everyone that joined us. Take care, have a lovely day, and we'll see you next week.